Okay, I was asked to introduce myself. I'm Dr. John Lewis. I'm one of the clinical supervisors at the Long Beach Mental Health Center, and I've been with DMH for about 14 years. Spent most of my time with, prior to coming to DMH, with the regional center system. I was a liaison to the LA County Sheriff's Department for about 9 years, and then prior to that, I was with the Lanterman Regional Center, and I worked in the courts, helping developmentally disabled defendants with reaching dispositions with the courts so that they, could work out misdemeanor charges and and felony charges, and working in conjunction with the public defenders and city attorneys. And so I'm also a ordained elder in the church, and also a seminary graduate. And so I've been asked to co-lead this workshop with Kumar, which I am elated to do so.
Thank you, Dr. Lewis. And my name is Kumar Menon, and I work in the Office of the Director for the Department of Mental Health. I worked in that office since 2000, and the reason I'm here presenting with Dr. Lewis is because I've been privileged to work in all the efforts the department has made since 2002 to work with the faith communities to address the connection between mental health and spirituality, and all the attempts we have been putting in place to operationalize for our public mental system a public agency. So it's a privilege to be here. I also happen to be a member of the California Mental Health and Spirituality Initiative, representing the county and the department. We have another member of the steering committee here from the initiative. Mr. Jay Mahler is actually founder of the initiative from Alameda County. So this particular subject, I'm here because I was involved in, along with Dr. Lewis, in creating the core of the presentation, the topic of the presentation. We're calling it considerations, but it really means what we have put in a document called Parameters for Spiritual Support. Having said that, I just want to show you what the outline of today's presentation is. These considerations part is everything below introduction. Those are the areas we considered in creating these parameters. And I want to go, there's some changes to your handouts. I left the competencies on your seats. It's not in your handout. In your handout, the PowerPoint slides, the learning objectives are different. There are 3 other learning objectives. These are the learning objectives we submitted for qualifying for CEU. Not to worry, we will cover all 6. And if you don't, raise your hand at the end of the presentation. We'll make sure we'll give you the information. Dr. Lewis, do you want to give a little bit about the session format?
Okay, and our format will continue. Kumar Menon will go through a definition of, we'll go over definitions, we'll go through the background, which will give you a summary of how today's workshop evolved, and a lot of the initiatives, a lot of the planning and development of services are taking place throughout the department, throughout the county, and even throughout the state. And then I'll talk a little bit more specifically about assessment issues when thinking about spirituality and the spirituality of clients and their families, and how they're interacting and relating to spiritual leaders and faith-based organizations and faith-based entities in the community, and how that plays out in an individual's life. Also, I'll be talking about treatment planning, what we call here in the department client coordination planning, and so how that comes right out of assessment, and how we can consider spirituality in developing an appropriate client care coordination plan and treatment planning when you're talking private practice and say in hospital practices and other mental health settings. And then boundaries, we'll be talking about boundaries specifically in the mental health setting and how we just want to have general considerations about how to use good good mental health judgment when we're talking about boundaries, not going too far, but not being so hesitant that we can't get involved in anything with our clients that might be of a spiritual nature outside the office setting. Okay, so boundaries will cover that. And administrative issues, I think Kumar will handle quite a bit of that.
And then we'll also go over staff training and some relationship with faith communities. That's the last bullet. I also want to acknowledge Dr. Frida Chung, who's also a member of the California State Mental Health and Spirituality Initiative. And you see some references to them throughout the presentation. Michael, our coordinator, is here. Did you want to mention anything about the CEU? I already talked to them about the videotaping.
Okay. Good afternoon, everyone. If you need some CEUs, please, I will be here with a stamp, and I can stamp on your evaluation in pink form there. Just before you leave the conference, just come by here and I'll give you a stamp. Thank you.
If you all are following along with me, we'll go right to definitions. The first one is spirituality, and that is defined as a person's deepest sense of belonging and connection to a higher power or transcendent life philosophy, which may not necessarily be related to an organized religious institution. So we talk about spirituality in relation to a person's connectedness with a higher power, a power other than themselves, a sense of otherness, a sense of connection. It may be, some people call that person God, some people call that person a higher power, some people may relate to other forms of a higher power. But the main thing is on a sense of a continuum. We're looking at spirituality, that people all have different levels of spirituality. They have different definitions of spirituality. If we went around this room, each person would have probably a little bit different definition of spirituality. And on that continuum, all the way from, well, I'm not very spiritual, or I'm not spiritual at all the way up to the point that I'm very spiritual, or I practice some type of formalized religion, or I'm ordained or something, So spirituality can be defined in several different ways, and it can be looked at in several different ways as we go throughout the definitions of spirituality. And so we'll get into that more as we move throughout our presentation. But a second definition of spirituality is a process of pursuing meaning and purpose in life. So again, I've talked about that, what's meaningful to one person, what's a meaningful lived experience for one person. If we did a study and we talked to an individual about what it meant to you, say as you were coming up in life, it might be different than what another person would explain as what was meaningful to them. But again, spirituality has several definitions, but the main thing is that we want to acknowledge spirituality in an individual's life and not just put it to the side and not acknowledge it at all, and not determine that it's not important as we go through our mental health implementation of mental health services for a person. So we're just looking at spirituality as a process of meaning and purpose. Religion, we talked about how religion on the far end of the continuum is a specific definition of spirituality. It's a practice. Religion is a formalized set of practices, a formalized set of beliefs, a system by which individual or groups or a group comes together and does what they do in terms of exploring, in terms of living, in terms of making it real for them in terms of their spiritual belief pattern. So that's where we get into quote unquote religion. And we have doctrines, we have things that are written down, history, of one particular belief system versus another particular belief system. That's when we talk about religion. Proselytize. We're gonna let. Kumar always gives me the easy ones, and I give him the hard ones.
Can I ask a question?
Yes, ma'am.
Spirituality, religion now doesn't include spiritual, supernatural being or God.
Yeah, that's what I mentioned, that that God, to some people, spirituality is God or a higher power, or could be something else. Remember, we talked about on the continuum that it could be certainly God, sure.
And it's a good segue into proselytizing as well. But I just want to, you might be wondering, why do we just start out with the definition? A couple of you heard this before. We didn't give you any primer. We just jumped right into a definition. That's because that's been our experience. Whenever we thought as a department or a group of us within the department trying to effect this as a practice in our public mental health system, first question we are asked is, oh wait, what are you talking about? Because a lot of people equate religion with spirituality, as he said, multiple meanings. So one of the first things we had to do in developing the core of this presentation, the parameters, is define what we're talking about. Now in the earlier group this came up, we defined it not really for our practitioners, anybody else, to tell anyone else this is what spirituality is and this is how it's going to be. No, this is just to set a standard, a general standard for us, for the department, that is as inclusive as possible. And you know, it's a minefield, this area. If a government agency tries to tell you what this is, that's a problem. This is just for our practice. We wanted to define in broad strokes things that are very inclusive. So, and in this context, to Frida's question, we took this to our clergy advisory committee. The department has a clergy advisory committee that guides and informs us on how we interact with the faith communities, etc. They told us somewhat the same point you made, Frida. What we agreed on doing is adding the word transcendent life philosophy. They felt the word transcendent alluded to God, something that is more divine in nature than just life philosophy or higher power. So we took their advice. I mean, by no means these definitions are going to be static. If there is some overwhelming consideration that comes up and says, you know, you guys got to change it, you know, our medical director's office will take everything into consideration and it might change it. Who knows? But then immediately came the other point. What about religion? So we had to define religion just to separate the two, really not to say that is the only definition of religion, and our advisory committee gave us that also. Proselytize, really the department's focus in many ways with this was, how can we provide support to our consumers and family members? And we do that all the time. I mean, you talk to our staff, they provide support all the time in many different ways, including in this area, mind you. But we wanted to make sure when we are getting into this kind of in a systematic way that we address the big white elephant in the room. No, I shouldn't use any color words in it. Big elephant in the room. And that is proselytization, because that was our biggest concern. With the power differential, all the other things that come with being a government agency, a service provider, we wanted to make sure that we address that. We are not imposing our views or anybody's views on our service recipients. In fact, the title of our parameter says client's interest, not our interest, not the provider's interest, it's the client's interest. And if at any point the client says to us, no, I don't want to talk about it, don't tell me anything about this, don't even ask me a question, we are obligated not to do it, because that's not our goal. Our goal is to really to support the client. So, worldview, we put it in there because it came up. This is very much a cultural competence topic. And then you'll see as we go through that it comes up. If you look at, I'm sure many of you are licensed folks in there. If you look up in your practice, conversations, published documents, etc., always comes up as part of some aspect of culture competency. So we wanted to make sure we address the worldview aspect of it, where a group has a specific view of the world around them, and that worldview sometimes affects their perception of illness, their perception of health, everything. So we wanted to throw that in there. Then the family part, we always want to clarify what we mean by family, because we usually mean a broad group of people, significant other. So that kind of addresses the definitions, and we wanted to start there. It was a big consideration. There were a lot of discussions when we did those definitions, a lot of back and forth. But now I want to go into a little bit of background, and this section of the background is going to address one of your learning objectives. You're asked to learn at least a couple of reasons why the Public Mental Health Agency is doing this. The 3 standard reasons that our director gives is that 1, the clients and family members have asked us for this kind of support. 2, it is part of culture competency. There are many communities where spirituality and access through faith-based communities are sometimes the only way to engage and probably get them into services, so you can't escape that. And the 3rd reason he always gives is that this is the underpinnings of building community support. The mental health system cannot do it alone. We serve over 200,000 people a year, but that doesn't cover everybody in need in LA County. And so we need partnership out there. This is a natural partnership. By engaging in this discussion, we are creating a link to community support, especially in the faith community or whatever other belief systems they have. But I also want to tell you about this, and if you attended the morning thing, I really am not going into the details of the first 2 points, because I think the keynote speakers emphasized that in many different ways. But the increasing recognition part, and then it's a important element of how we deal with chronic illness, suffering, and loss. One reference that I have in the handout, is by Diane Corna. It's a lit review done for UK, but it gives a nice overview of all the things. I also included a reference for Simon Dean, who did a lit review in Psychiatric Times. It gives you a nice reference. I also direct you to look at Jewish Foundation and Christina Pachalski, who has done a lot of work in this area. And they all tell you the same thing, that number 1 and number 2. And the 3rd bullet point I want to cover, and you see that acronym there, according to a CMHSI survey. That's the California Mental Health and Spirituality Initiative I was talking about. The initiative was funded by 51 out of 58 counties, Jay, right? 6 counties, yeah, in California. And one of the things that the initiative did was did a survey of consumers and family members throughout the state of California. Now I'll tell you a little bit about the actual findings of that study, because it really tells you yes.
What initiative are we talking about?
It's called the California Mental Health and Spirituality Initiative. It is housed in the California Institute for Mental Health under their Multicultural Center for Multicultural Development. And we are so happy to have a 3rd member of our steering committee here. It just so happens Reverend Laura Mancuso, Dr. Frida Chung, Jay Mahler, and myself are part of the steering committee on this.
We have a quorum. We might actually have a meeting right now.
Initially, when it came to be in 2008, I think it was officially housed in CIMH. All the county directors supported it. The survey conducted, they also conducted a survey of all the behavioral health directors that gave a lot of support and feedback on this. So for more about the initiative, Nancy, right? Nick, you may want to check out our website, www.mhspirit.org. It'll give you a lot more information. So in the survey, they did, I think, over 26. In fact, Reverend Mancuso was one of the surveyors. Over 2,600 respondents, right? 75% of mental health consumers and family members indicated that spirituality is important. 58% agreed that mental health providers have demonstrated respect for their spiritual life. That leaves a good, 42% that we should make some impact on, and hopefully our parameters and our training will make some impact there. 2/3 of the respondents agreed that the public mental health system in California should do more to support clients and families in utilizing their spirituality. 74% indicated that mental health providers should be willing to discuss spiritual concerns with them. And 66% agree that it's appropriate for public mental health system to address this as part of mental health care. 12% disagreed, which roughly equates to what you find out in the nation, around the nation, about acceptance of religion, spirituality kind of things, yeah. So basically it says 1 in 8 service users in California may not want spirituality in their recovery, but the other 7 do. So, we have to do this. The Department of Mental Health saw express need to do this, but we have to do it right. When we went to our staff, the first thing they told us, the actual people who provide services, is that, our schools and training told us to stay away from it, basically. And many of them still do. Tell us how to approach this without keeping all our boundaries, all our things, doing it properly, and then we can maybe consider doing it. Yes.
I would like to see qualified consumers trained, that were trained as peer supporters and services standards to somehow address this issue with the department.
Fantastic. In fact,
culturally speaking.
yeah. Interestingly, Phyllis, Sharon made the same point in the previous workshop. We haven't gone to the details of some of the actual support practices, but I see peer support as a big, big component of this, and so does many folks, and I'm sure our director does too. In fact, when it comes to some of the actual tools that our service recipients may use, we see self-help groups, peer-led efforts are being the means to do this, whether they're in the community or not, because in some instances the department cannot ask you to lead a particular kind of group, etc. It has to be a self-help, peer-led kind of effort. So, good point, thank you. Spirituality has received attention in practice-related documents. DSM-4 has a section, V code, on religious and spiritual problems. One of our steering committee members, Dr. Lukoff, was involved in actually putting that in the DSM-4 TR in 1994. He says it's an acknowledgement that this needs to be taken seriously. And it also actually leads to some other aspects, a point that was raised in the previous workshop about extreme religiosity and how do you separate some of the mental health aspects of it from actual spiritual practice and interest that supports the clients. And hopefully you'll address some of that in the assessment part, TX part. The practice-related document, psychiatry, psychology, they all mention religion and spirituality competence as part of cultural competence in their training programs. So it goes on and on. The APA at one point put out a resource document from one of their committees that really spelled out the do's and don'ts. Interesting enough, this is the American Psychiatric Association. I couldn't find the document now. It's in your list of reference. If you see it and you can't get the link to work, it's because they took it away. I don't know why. But interestingly enough, it was not an official document. Yeah, it was not an official document because it was by a committee. It was an opinion. But in that, they made a couple of things, and this relates back to proselytizing. It says that you should be sensitive and supportive of the client's interests and practices and beliefs, but at no point should you impose your own practice or belief, and at no point should you think that a religious practice or belief is something you can substitute as a practitioner for clinical care. So that's in gist, and I don't see it anymore, but I thought it was a good point about differentiating the role, because our focus in public mental health system is not on the divine. it's on the other things, coping styles, locus of control, social support, and apparently there are physiological impact on bodies that are associated with spirituality and religion, etc. And lastly, something that all of us have experienced in different ways, even if in some cases interacting with nature, that is the uplifting presence of built environment. And some people have anecdotally said how they walk into a place of worship or sit at the beautiful sunset and get this notion of, calmness, balance, centering, etc. All that is part of our focus. I mean, because that's all part of being well and the recovery process, etc. But not the divine. The divine part is we leave it to the faith community, to the experts in that area. So I just want to be clear about that. A little bit more, and I'm going to not do too much on this because we ran out of time doing this and a lot of questions came up, but it's basically the history. This conference is really kind of the starting point back in 2002. Interestingly enough, the opening act for that 2002 Breakfast for Clergy was someone called Pearl Ella Johnson, who was a fantastic consumer advocate that was based in LA County. And it was a signature, it doesn't matter where she was invited to speak. She would come in singing the song, "This is the day the Lord has made." And, that's her. I mean, didn't matter what people in the audience thought of it. That was her. It was central to her recovery. She went from being homeless on the street, extremely ill, to a successful advocate, employed by the department, an international speaker on the subject of recovery. So it's a great start, and we have slowly built momentum, and we are putting actually the rubber that can hit the road really with these parameters and the considerations. So with that, I'll turn it over to Dr. Luis to talk about assessment.
Pastor, I'm working presently as a hospital chaplain, but today I have never heard so many acronyms, so many initials, so many words that I don't understand. We're going to have to teach us the language to help us to get involved in mental health. I don't know the language. I'm learning, I'm trying, I'm not stupid, but I just don't know. And sometimes we're going to have to get the language going with us as well to plug in. I just feel sort of lost with, I know Jaco, I mean,
Yeah,
the word we use at the hospital, but the language is just foreign to me.
Yeah. And please, for today's presentation, stop us and ask if there is a acronym or a word. We'll try. I mean,
Yeah, I mean, I understand you've got to move along, but I'm just saying that some kind of this is going to have to be built into the process.
Any acronyms, like Kumar is saying, you can always write them down and give us a call, and we'll explain them to you. That's what we're here for. We're here to exchange. We're here to, I think, we're reaching out the hand to shake your hand and bring you into what we do, and vice versa. I kind of on both sides of the fence. I'm clergy and mental health, so I know both languages. So don't feel bad about writing it down and asking the question. Nothing's gonna replace if you got somebody that's been through graduate programs and all these licensure and all this, nothing's gonna replace that with going through it. But like I said, if you write words down, write down acronyms and things of that nature, and vice versa. I mean, mental health needs to write down if they hear something of a spiritual nature, a term, a concept, or something of that nature, then they need to write it down too, so they can get clarification. Yes, ma'am.
This is an opportunity, what I was mentioning earlier. The doctor here is saying in a real life situation with information, this is some of the information I want to see peers use. And I am working with the program for gift development for the exceptionals, because it is so important. We have a gentleman that was earlier in the back, the minister, that have a whole program as a training. Those are the breakers. That's what closes that divide. When you have individuals in the same room asking for this, I'm hoping that comes out of it too, that I hope that there's training between the two of yourself, Kumar and yourself. You can put this together so more consumers can put answers out there for the community because we're taking and reeling it back and it's going back and forth. But this is this is opportunity. The acronyms that we've been living with, the teaching that's out there available, merging them, it is so important because I got a figure from the Center for Disease Control says 1 in 2 individuals suffer from some type of psychosis. 1 in 2. I'll take the number 1 position. I'll always take that. So myself with that 1 position, I know that I need experts out there in every sector. So this is something to where he's putting that together, where I'm just backing up my information. Peers need to be utilized a lot more as paraprofessionals.
And we have to, remember as we're learning all these new tools and new words and vocabulary and what have you, whether it be in the form of a glossary or whether it be in the form of a dictionary, some type of document, a manual or what have you, we have to learn, stay within our scope. Also, if we hear something, if we see something, if you have a definition of depression or schizophrenia or bipolar disorder or severe anxiety or, all these different things in which, mental health encounters every day, or substance abuse disorder. Sometimes we heard earlier that, where traditionally, some might try to, just pray it away or something. Well, then, but we work hand in hand. That's where, you can get some experts in the field of substance abuse recovery, experts in the field of mental health recovery to work together where you can put the two together. If this person decides, well, I like prayer too. This person decides I like mental health intervention too and substance abuse recovery. We can work as a team, to try to help that individual. It doesn't have to just be one or the other. And push them off on the other. So
to some extent, I feel like I'm out of my scope and out of my wealth of understanding, but this is how I learn. This is by putting myself in a situation where I am going to learn a new vocabulary. I will see a different perspective, and I will have a given set of definitions that is agreed upon by the majority in which we communicate. But this is how we all learn.
Yeah.
But also remember to stay within your scope too, right? That's very, very important. Because I'm getting ready to go over assessment. So when we're assessing something, if we pick up something, and it's outside of our scope, like if it's a medical issue, who do we turn to? We turn to our primary care physician.
True.
We don't try to, find out why this person is hurting or has a problem inside, a pain in their stomach. Well, they need to see their doctor first, okay? So let's go ahead on into assessment. Let's talk about when, why, when do we introduce the issue of spirituality as we're going through, say, an assessment of someone. And we're talking specifically about a clinical assessment. If we're getting into a bio, psycho, social, substance abuse, whether it be a trauma-related assessment, whether it be something related to cultural or family-related issue. How do we introduce spirituality into that? At what point did we start talking about, why don't you tell me a little bit about your background, your family? Do you have a religious belief? I mean, that could be a sensitive issue. If you don't handle it the right way, you might, repulse the client from you. And the client maybe has never heard that before in a mental health setting. Some clients have been coming to mental health for 10 years or 15 or 20 years. Now all of a sudden, you're coming at them with a spiritual issue. And that might turn them off if you don't do it the right way and have the right timing involved, right? So you have to first connect with that client. You have to first establish rapport with that client. You have to also have some kind of working relationship with that individual. How much have you, developed that relationship and self-disclosed to where that person feels comfortable talking to you about the practices that they've been involved with in their home many times since they were a little bitty child. When you're talking about religious practices, a lot of times it was their father's father, their mother, and their mother's mother. This has been going on for years and years. So when, where, and how, these are considerations that you that you have to make as a clinician, as a case manager, getting involved in the issue of spirituality. You know, how strong do you come on? Do you say, well, I want to know everything about what you did from a spiritual nature? Or do you just kind of introduce it and talk just a little bit about it and kind of fill the person out a little bit and then save some for the next session and maybe the next session and the next session, okay? And then just introduce it gradually. And then what you're trying to find out are things they're going to help the client. But as you're trying to find out things that will help the client, maybe you find out something that's been harmful to the client throughout their lifestyle. You know, maybe they come from a family that's been, alcoholic or something, alcoholic family. Maybe you find out something from an abusive standpoint, you know, abusive emotionally, abusive physically, abusive mentally, abusive sexually. And now you find this out and you've been talking to them about spirituality. Now what are you going to do with this information? Are you going to back off of them now because of a spiritual issue? Are you going to have enough competence, cultural competence, to be able to engage them in it? Maybe it's a religion that you've never heard of before. Now how are you going to develop a competent treatment plan if you've never heard of the spiritual level that they've been involved in or the religion that they've practiced all their life, and you're not willing to learn anything about it? You know, you're distant from them. You're distancing yourself from them. You brought this up. Now you're not ready to engage them in relation to that. So that's kind of where what you're hearing from the department. It's time for us not to be so worried about what we might be thinking, but what's important to the client. And we as professionals to be strong enough to engage this client, and specifically as long as it is normatively appropriate, they're not doing something that is harmful or something that is dangerous to them or someone else, that we're able to engage them and try to help them and try to understand them and understand their background and their family involvement. I saw a question over here. Yes.
How do you separate trauma, war, and person's religion that's in your spirituality counseling?
Or trauma of war? There could be something spiritually related to the person's experiences in the trauma of war. Maybe that's what kept them alive, or maybe they had to have something of a spiritual nature that kept them strong after being traumatized by seeing their buddy being killed, or seeing somebody losing a limb, or seeing they're experiencing PTSD or some type of trauma related to the ills of war.
You've probably been involved with trauma groups, and how's the success rate of that been?
The success rate of trauma groups?
Yeah.
I don't have specific numbers for you.
Basically.
Well, again, I don't know. I mean, I know that spirituality can be used in that regard if you respect the individual, respect their experience, where they're coming from, listen to what they're telling you, connect with them in terms of understanding, where they're coming from and where they're going. And again, is it normatively appropriate what they're talking about? Yes, sir.
Well, the assessment and kind of meeting the person where they're at, and I appreciate the way you were talking about kind of figuring out what's the timing. You do a full assessment, you do it gradually. I was at a workshop this morning with Pacific Clinics, and there's been assessment tools that have been developed. Some of them have a list of questions and kind of raised for me, well, meet the person where they're at, do it gradually, the relationship with them. So I get a little worried sometimes about having assessment tools, feeling you may have to go through it in a certain amount of time, get it done, get the assessment done, and kind of get it to bureaucrats. But I appreciate what you said, because you kind of indicated meet the person where they're at. It may take a while to have that kind of sense. So anything more you can say about that?
Well, just
Tools,
remember the assessment is an ongoing process.
Okay.
Of course, when you begin to assess the person, in the Department of Mental Health, we have our 5-page adult initial assessment, or for kids, it's like an 8-page assessment, or 10 pages, or whatever it is now. It keeps changing, but the point is, we have these assessments that we need to complete. We have a certain amount of time we need to get them done. We have a certain amount of time we have to get our client care coordination plan done. Then we do them again annually. We have an annual review update that we do annually. Okay? So that kind of documentation has to be done on a routine basis. But a general clinical assessment is being done continuously. So when you're talking about timing and involved in introducing the spiritual element of how I can help this client because of what I'm learning about them as a spiritual being, then that is something that goes on all the time. You have to have this feeling about between you and your client as to, is this a good time to talk about it? Does the client trust me enough as a professional, number one, that I'm going to be authentic with this person, that I'm not going to breach our confidentiality and go talking to other people about it, that I'm going to be, trustworthy with this information. I'm not going to mislead what goes on in the chart when I write it down. I'm going to write it down, only what I need to write down, and we're going to have a real person-to-person exchange and experience about what's going on. I may disclose some about myself. I may not tell them everything. I may not tell them where I go to church on Sunday morning or Saturday evening, or I may not tell them that, but I may, divulge some things about myself. Well, just to connect with that person, just to let them know that, that I'm there for them, and I'm asking these things not just because it's a point of interest, not just because the department told me to do it, but because it's important, because it's meaningful to them, and it's meaningful to me trying to help them. Somebody else? We're going to keep moving, but go ahead. I'm going to pick up these next two questions.
Yeah, because of my scope and I deal with co-occurring disorders, it's a little easier for me to go into that because of treatment.
Sure.
I have to talk about spirituality at one point or another, or it's going to be necessary. However, when I'm dealing with like a Korean or Asian member, I have to be a lot more sensitive. Whereas I would normally, I could normally approach that in the first few sessions. I may wait until the therapeutic relationship is really getting established. And then I can kind of fall. Because I know that somewhere along the line, that's going to play a serious part in their treatment. Because they're going to need something, with what I found, to help them come between that mental part of their co-occurring disorder.
Well, one of the best things you can do, what I found works, is if you're not familiar with a person's particular religious style, ask them about it. Let them educate you. You don't have to have all the answers. We already have this one-upsmanship about ourselves because we're the professionals, right? We're supposed to know everything, and that's just a given, whether we think we do, whether we tell them we do or not. But that's just the way it is. And so you can ask them, tell me more about, what was important to you as a child. What was important to your mother? What was important to your father? How did things go in your home? And that really tells you a lot about that client. How did you and your brothers and sisters get along? Who was important to you? Was it a spiritual leader in your community that was important to you? A spiritual organization? All these things that the person tells you can orientate you and can educate you. Then when you go after the session, you can always look it up a little bit on Google, and next time you come back, a little bit more. Now you can exchange with them. They go, hey, this person thought I was important enough to look it up and tell me something about my background and a little bit more about me. And maybe you have a colleague that can enlighten you some too. See, the learning process is tremendous when you start this whole relational issue and this whole thing of engagement and rapport building and connection, because this connectedness is one of the biggest things you have in treatment. Yes, and we're going to move on.
I just wondered if you talked about how, when we have a certain problem, we go to that professional that's, to take care of it, such as the doctor, the all that kind of thing. When you got an assessment with a client and you come to realize that you don't know about their religion, would it not make sense at that point, if you're not really a faith-based clinician, but would it make sense at that point to refer to that like-minded faith-based clinician? I mean, is that not the whole idea of bringing together the GMH and the faith-based organizations
to be able to have that resource to say, this is what this person wants.
Well, I mean, you know, and if we had an ideal world, that might work, you know, where every time somebody brings something up you don't know about, you refer them to someone else. But that doesn't always work that way, you know. The department wants us to be educated, just like when the department wanted us to be more educated about co-occurring disorders. Everybody remember that? You know, about substance abuse and co-occurring mental health disorders. It's kind of the same thing. We need to educate ourselves about spirituality in general. It's not that we're trying to become religious experts or anything like that. It's that you have a general working knowledge about spirituality and about spiritual interests in general. There's a generality that you can bring to the table about spirituality where if you don't know anything about a specific religion or not. And like I said, you can learn about different religions. It doesn't take a whole lot of time to learn something about a religion. Take a few minutes to learn something about it. And then you can engage behind. That doesn't mean that you create an imbalance in your clinical setting where this is all you talk about now is just spiritual things with this client. You still are going to maintain your clinical expertise. You're still going to maintain your clinical interventions. You're going to still continue your clinical assessment and everything. You're not going to create an imbalance where it's all spirituality now. You're just going to integrate it and keep it as part of the the learning process and as part of you being able to help the client, to not exclude it. That's what you don't want to exclude that, okay? But I don't think every time somebody says, I'm this or I'm that or this was my experience, and you're not familiar with it, that you're going to refer them out. I don't think it's going to happen like that. Because we be referring out all of our clients. I don't think that's going to happen. Or a lot of them anyway. Not all of them, but a lot of them. Okay, did I answer your question? All right. Let's keep moving. Let's talk about treatment. Okay, I'll answer your question in a minute, okay? Let's talk about treatment. I know this perks a lot of interest, this discussion. And maybe this perks, what we need for a dialogue, so we can all just sit down and get all of our questions out and, all of those answers, answered and everything, and, just spend some time together. Treatment. We know that treatment planning, or what we call in the department, client care coordination planning, but specifically treatment planning comes directly out of your clinical assessment. All these things that you find out during this assessment time, the first 1, 2, 3 times that you meet with the person, their background, the things that have troubled them as you're defining the problem for the individual, as you're doing all these kinds of things, as you're seeing what has been helpful and supportive and what has been a strength or a coping mechanism for this person in the past, this helps you to develop your treatment plan or your goals for treatment. They go right into the client care coordination plan. So if the person's had problems with alcohol, maybe alcohol's been okay in the family since they can remember. And it hasn't necessarily been a religious problem or a spiritual problem, but now they're into spirituality and they're trying to improve themselves from a self-help standpoint, from a recovery standpoint, but they find themselves still drinking. Well, maybe they need to find a spiritual or self-help group or self-help advisor or a counselor, and from a spiritual or a higher power standpoint, get a power greater than themselves to help them to stop that drinking, because maybe they can't do it themselves. They've been so enmeshed in this drinking problem. Maybe it's happened in their home from day one. It's been okay. It's been normative in their home, and they've just been drinking right on. But it's been a problem. So now that becomes a focal part of treatment. We want to refer them to a program. Maybe it's a program that stresses spirituality or has a spiritual component. The 12 steps are based on a spiritual component, and they come right out of that, a God or a higher power, depends on what book you're looking at. And so you want to help the client in that respect. So treatment planning comes right out of your assessment. Problem definition as you're going through assessment might have been early on in life, could have been a little later in life, something that happened to them during life, a trauma. You know, we talked about a physical, a psychological, a mental, a physical trauma, something that they have not unpacked, something that they have not dealt with, but that might be something they need to deal with in treatment right now. They've been carrying it around for the last 20, 25 years, and they need to deal with that in treatment. And if spirituality is going to help them do that, they might be seeing you, and they might need to see somebody else. Likewise, a pastoral counselor, if that be the person, or a spiritual leader per se, if that person is going to help them, then so be it. You know, and you can, you know, give them several resources, help them to find the appropriate person that they would be looking for, and let that be part of their treatment plan. So now they're focusing on the alcohol, they're focusing on the trauma, and whatever other goal, a case management goal or a family-related goal, 1 or 2 or 3 goals for treatment planning. Any questions on treatment planning? Let's move on to boundaries. Yes, ma'am. Sorry, I didn't get to your question.
That's kind of what you just said. I'm finding that consumers are kind of nowadays finding spirituality and using the pathway of healing themselves in various ways. And it's been a long time since I've been in a mental health clinic as a patient, but I was wondering if the trend was nowadays to have groups for consumers for them to let other people in the group know what their meaning of spirituality is.
Well, I mean, hopefully the group that they're involved in, whether it be in the clinic or outside of the clinic, hopefully that group is open to a person's spirituality and a person's spiritual beliefs.
A lot of people like me, didn't even know what spirituality meant. I just thought of going to church and believing in God. Of course, there's a lot of other components, and I feel everybody should be able to know, differences and the choices.
Well, there's a difference between a spirituality group and, say, just a self-help group or a depression group or women's group.
Some people are struggling with spirituality is what I meant. That's why I think it should be clearly defined.
Yeah, there's all kind of groups, but if you want a spirituality group, you should find a spirituality group because they focus purely on spirituality.
Yeah.
Okay?
I happen to know of one at Long Beach Mental Health Center that's peer run. It's a very good group.
And who started that group? Okay. Anyway, boundaries, we're moving on. Boundaries. Any other questions about treatment planning? Any other questions about treatment planning? Okay, boundaries. What are boundaries? Boundaries are, within the window. We don't want to go outside the window, right? We can stay inside the window. So we're talking about spirituality, we're talking about all this trauma, we're talking about, the experiences of individuals, we're self-disclosing a little bit, we're engaging the client. We want the client to trust us and feel comfortable with us, so the client can get help. We want the client to tell us about themselves, right? But the boundary is, how far do you go? The client starts telling you, well, I need a ride to work tomorrow. Can you come by my house and pick me up at 7 o'clock and take me to work? Or my cousin passed away or something, can you come pick me up and we're going to go to the funeral?
We got $5.
You have to decide, at what point is it crossing boundaries? It's okay to do some things. We're not saying that you shouldn't do anything. But you have to use good clinical and sound judgment. If you have a question, that's what supervisor's for. Everybody has a supervisor, right? So everybody answers to somebody. If you're in private practice, you got, the board, or you got NASW, or you got the Psychology Association, or psychiatry or somebody, you have somebody, or you have a colleague or somebody you can talk to ask questions. You know, if you clergy, you have another clergy brother or sister that you can, you know, ask questions of. You know, does this sound like a good idea to you? And if it doesn't sound right, then you probably shouldn't be doing it. You know, so that's boundary issues, okay? And so that's where in the department, they're not saying if you think, you know, that going to a funeral and you want to sit, you know, in the back of the funeral or something to support this client, that's not necessarily the worst thing in the world. You know, you might do that. You know, are you going to do that for every client? Maybe, maybe not. Then you may have to explain to your client why you did it for this one and you didn't do it for that one. So it could be a tough call sometimes, yes.
Then you need to maybe talk to your client, the consumer who attend that religious service, you know, how do you, who are you and how you can explain your relationship to the consumer without breaking your confidentiality. So it gets really complicated. But I know a number of years ago, a colleague has sent Christmas cards out to their a number of clients. And their supervisor said, well, are you sending cards out to everybody? So they had to think about that, you know, because you always have to look at, you know, why you're doing something, you know, and are you treating this person different because of their particular religion and maybe you belong to that and feel more kinship. So it's not something that, it needs something that needs to be discussed, not just making your own decision all the time, to bringing colleagues, supervisor, peers, or
So as including this section, under no circumstances should staff take action that create an appearance of proselytizing. So, you know, you don't want them to come with you and join up your organization, and you don't want to start joining their organization. You know, just that appearance, you're proselytizing.
Sending out Christmas cards sounds like proselytizing.
Well, yeah, it could be. It could be. For a card for that season. I mean, if you're just sending out a nice card. But if it's a Christmas card, yeah. But they have other cards that don't have a Christmas connotation. So there are ways of getting around, and you can still, be nice to the client. I mean, but like she's saying, if you do one for one, you might have to explain to all of them. So you got to be careful with that. And then if one client gives you a card and you take it, and then the other client's going to give you a card, but you don't want to be radical, and don't ever take anything from anybody. So, I'm sure we've all had to cross that bridge at one time in our career. The main thing is just be aware of boundaries, not stepping outside that window. You got that window for yourself, and you want to stay inside. Okay? Go ahead. I'm going to let Kumar take over. I'm going to take one last question.
I mean, we're talking about things of how, if we're talking about confidentiality, none of the clients will know about the other client what they do because their needs are different. We don't have to explain why we went to them, because we wouldn't even know our clients. We're not supposed to talk to other clients. So that is not breaking the personal boundaries. And also, if you're going at the request of the client somewhere, if they say, I want you to come to this funeral, then they don't care about that confidentiality. It's up to them to say she's my therapist or he's my therapist or not. Because if they open the confidentiality to other people, it's not our responsibility. So all these questions that are being asked, I think they have to do with proper training. And if we don't have the proper training, we don't have the answers. But if we do have proper training, the answers are there.
Well, again, you just have to use judgment. I mean, there's no one right answer. That's the thing, because you can.
Because every client is different.
Yeah.
But the question that I hear is, I'm saying is already boundaries are explained how we deal with it.
Yeah.
Including
All right. Okay.
Is there a working definition of prophetizing in here?
Yeah, right on the first page.
Okay.
Or definitions. It's on the page of definitions.
Okay.
Go ahead, Kumar. I'm gonna hand it off to Kumar. How much time? What's our time looking like?
We got, it's 4:40 until 4:45, right?
Oh, okay.
We're about
So we got
35
about
minutes.
40 minutes. We're okay.
35 minutes.
Yeah.
You know, and I want to start where you left off, Dr. Lewis, and that has to do with the appearance of proselytizing. The department has put together a training plan, and you'll see some of the competencies towards the end. One of the initial training is an introductory training, and the question came up, and our medical director was the one talking about the parameters. And the question was, my client asked me to pray with them. Can I? And Dr. Shaner, our medical director, said, no, you cannot. Another clinician in the room said, why not? It's the client asking you to do something to support them, and if you're willing to do it, why not do it? You know. And he said, he quoted this thing about appearance of proselytizing, and the point is that the department, as a public agency, cannot ask a practitioner to pray for their client. That's not in our repertoire of services we provide. We cannot officially ask anybody to do that. Again, you know, we can only officially ask our staff to provide clinical services, not anything to do with the divine. The belief may be there, and if you ask me, is it happening today in our system? I'm sure it's happening many times over. But officially, our medical director or the department cannot tell you to do it. On the other hand, the other point that was raised, I also want to touch upon is, what if you feel your belief may not be completely attuned to the clients? Should I pass them on? You have to be careful there. You have to refer to the professional judgment. You have to really know that your position as a service provider is not effective because of that connection, hence you're referring. Because for any other reason, it can be seen as discrimination. You have to rely that it's somehow you feel your competency is at stake here in delivering good services to this person. And we recommend, if those kind of issues will come up, we cannot address each and every one of them. And you should have a discussion with your supervisor about that. I mean, there's no one answer, and Nancy's point is well taken too. There are some of these things, and there is some discourse about how to handle this. If you have questions, first of all, that's a good point. If you have a question about something you're supposed to do, the easiest answer is don't do it. The second answer is please discuss, you know, with your colleagues, with your fellow practitioner, supervisor. So I want to leave the boundary part with that and go into administrative things. Now, I want to also recap. The title of the presentation is consideration. So we've gone through the first consideration, definition. We had to address the assessment part. We had to address the treatment planning. We had to address boundaries. The next thing that came up for us is administrative. And as frontline practitioners or peer supporters, it may not be your cup of tea, but look at this. The topic that came up was about requesting specific services. I know cultural competency is a big thing. I mean, it's mandated by Fed, state, we do it. It's the right thing to do. It's in many cases, it affects the effectiveness of services. But we thought, this is a potential question that'll come up. I am of such and such faith, and I prefer a service provider of my faith. Do you have one? We believe in the overall scheme of things. That's a good thing. You know, if we can provide that kind of matching, and if it's helpful to that person. Same thing, we believe in language, ethnicity, etc. We get all kinds of requests. Medicaid rule or Medi-Cal rule says they have the right to choice. So this is the process we identified. We cannot satisfy this all the time. Our system today cannot do it for many things in this way. So first, we have to affirm. We're telling our staff, we have to affirm they have the right to choose the provider of their choice. That we can try to honor the degree, to the degree possible, but may not be always possible. But this is critical, regardless of whether there was a clean match or not, or whatever things we were trying to match, that we are non-discriminatory, our services are non-discriminatory, and our staff, by their very training and profession, they provide ethical services. So this is not, you're not going to face, shouldn't face any negative consequences because we didn't meet your thing. So Yes.
Okay, so a point of clarification, I'm an acupuncturist and primary healthcare provider. In the assessment, when I have observed that a patient client is of a particular faith or religion, and on their own has specified an interest in practitioners of their faith base of choice, is it then not proselytizing for me to refer them to parishioners, clergy people, or practitioners? That wouldn't be proselytizing because it is consent?
Well, I want to differentiate that change of provider thing. We are only talking about mental health providers.
Okay.
We are not talking about referring to the faith community at all, whether it's pastoral counselors, spiritual advisors, spiritual leaders, clergy. We're not talking about referring outside the mental health profession at this point.
Okay.
So the choice that consumers, the Medicaid recipients typically have with our system is that they can choose the setting that we get the services in, and within that setting they can choose who is going to give them the services. So that's the choice I'm talking about.
Okay, I understand.
Yeah.
Thank you.
Now, we will get to that part when we get to the relationship with the external bodies. That's a good question, though. It's a tricky area for us as a public agency.
Thank you.
That changes one day.
Yeah, I hope so, too. But as long as, I really think, proselytizing is a key part. As long as we are not imposing on people's viewpoints, is my personal take. We're not imposing things on people. We're just helping them. I think everything is possible.
I think there's a big difference between the word proselytizing and referral.
Yes. But the referral, the question we'll address is, be careful how you refer, because that can have the appearance of proselytizing. And we'll, so the last one, the last bullet we have in administrative issues, we just want to make sure we put it there because the non-discrimination rules are there. Everybody knows we can't discriminate. And then the point I addressed about wanting to match clients and discrimination, why you would refer them out to a different provider, not out to a different provider. There are problems if you think you believe that your belief system doesn't really support the belief system of the client for whatever reasons, and you don't want to deal with them. You don't have any negative feelings towards it, but you don't want to deal with them, and you're referring out, that could be seen as a discrimination. There's California has what you call an Unruh Act, and it actually a provider very nicely referred a person of a different sexual orientation who was pregnant. I'm actually citing a case to a different provider very nicely. They talked about it, said, I'm not really comfortable serving you. I'm of strong belief. I don't believe in this. Please, you should go get served somewhere else. And the person said, sure, no problem. But later on, they sued. They sued and they won in California court. So very gray area. So you have to be careful about the professional intent, about making sure that you're doing the change of provider for the right reasons. Here is the next section, the staff training, and then we got one more section that is the relationships. Dr. Lewis, shall we address the staff training last, because this we have to go over the competencies. Can we go to the relationship really fast? Okay. So not to lose the continuity of thought, this is the part where the referral part I was talking about. These are the things we came up with. These were the considerations. Of course, we are dealing with spiritual issues. Now we have to think about what are the resources in the community. We are not delivering spiritual services. It is the domain of the faith community. And we know our service recipients want some support. How do you refer? That letter in caps, capital letters. Staff should not make formal referrals for clients to a specific spiritual or religious resource. And we changed the language a little bit to clarify. Now, we haven't put it into publication yet. We want to say, if you are a provider of services to a client, you cannot advise the client to go to a specific religious resource. You can assist them in exploring all the resources that may be of interest to them and let them choose. So that's the little part our risk management said, we can't ask them to send them to a specific place. You can give them a choice, let them choose. It has to be their choice. It has to be the client's choice. It's the client's interest. That's the real big part, and then we advise them about talking to the managers. Again, our system is, in a formal way, we are new to this. So we want to make sure we have as many checks and balances. So any gray area, we want more discussion. We want the program manager involved, and some of you already suggested that. We'll go back to the training now. I just want to get that out of the way. This is one of the learning expectations here, and related to this training, we'll go over the competencies. Dr. Lewis, you want to just go over the training?
Yeah, training and spiritual, religious assessment, case formulation, and treatment planning should be a part of both clinical and cultural competence training on an ongoing basis. So a lot of that we talked about, assessment and case formulation. Certainly as clinicians, case managers, we want to have strong assessment skills. We want to be able to assess for, any kind of problems, any history with a client that, difficulties they've had, strengths that they've experienced in their lives, family issues that have been a strength or might be a potential impediment to that person making progress. And so topics covered by training should include important clinical and administrative issues related to spiritual and religious aspects of assessment and treatment. So we talked a little bit before about how often we do these clinical assessments. We want those assessments to be individualized. We don't want to just do them just to get them done. We want them to be individualized, taking pertinent information, specific and germane to that particular client, their specific background, their history, how their developmental history went, and all those kinds of things. And so, specifically related to assessment and treatment. Remember, we talked about the treatment planning comes directly out of the assessment. And so training will be, rolled out related to all those things, assessment and treatment. Then,
Excuse me,
Yeah.
a quick question about the staff training. Does that also include the psychiatrists that work through the county? Do they also have to attend the cultural competency and et cetera classes?
Yeah, I would think so. In this particular case, we have a training plan that's related to these parameters, and your point is well taken. Lots of training. It's a new area, a lot of questions, a lot of gray areas. We have a whole training plan that has a intermediate, advanced, introductory, intermediate, and advanced levels. Right now, we have introduced the curriculum for the introductory training. It's a very general training. We are encouraging everybody to attend. Anybody to do a direct service. That is licensed professionals, paraprofessionals, peers, family extenders, and any other case managers, all the other staff to attend, because it's taking them before they even get into assessment and treatment. It's taking them into an area of comfort. A lot of them are uncomfortable because they don't have the training to address this issue. They shy away from it. They shut people off. They don't respond. They change the subject. So we want to give them a comfort level that they're not crossing any boundaries. They're not violating the separation of church and state and all that things. And at the same time, be sensitive to the diversity of belief systems we have in our service recipients. And so that's the introductory training. It's a general get to know everything. Everybody attends that. But we want all licensed professionals to go to the assessment, treatment, and the advanced levels of courses.
Thank you very much. Sorry for the interruption.
all right, definitions and explorations of spirituality, worldviews, and religious practices. So that, starts to give you a broader definition, a broader outlook on the delivery of services from a wider perspective, a wider spectrum on religion and spirituality and mental health. So, you know, the idea is that folks become competent not only from the faith-based community, but also from, you know, within mental health itself, that they begin to understand what these words, you know, worldview. You'd be surprised how many folks wrestle with that word worldview. You know, what does that mean? You know, my definition is that it means how my society or American society views the world as opposed to other societies or civilizations view the world, you know. Or it could also mean how an individual within this society views the world. So worldview. So you're going to learn a lot about that and how it plays out in context to the delivery of mental health setting in a mental health context. Because, you know, mental health is growing, it's getting larger. The substance abuse community is growing, the faith-based community is growing. All these systems are growing. We're all, you know, working together, and so that's what we need to learn, how we can better work together to service that individual that's going to be sitting there in front of you. Wellness and recovery, you know, those are some easy words to kind of understand. You know, but those are some big fields. You know, wellness and the recovery field. This is not only you know, here locally. It's even a national trend. You know, wellness and recovery. Here you hear about RAP, Wellness Recovery Action Planning. Everybody's heard about that before. You know, Mary Ellen Copeland, and so. You know, it's a lot going down, right? Not just here locally, but throughout the nation. And so, you know, the more you can learn, the more prepared you will be to offer and deliver services as pastors and your parishioner, as spiritual leaders among your organization, you know, attendees, and as mental health professionals within the mental health community. Discussion of therapeutic dynamics and cultural biases related to spirituality and religion. You know, what are your cultural biases? What do you bring to the table? You know, what did you learn versus what this other person learned? So you may have differences from this other person. You know, are you going to bring those biases in and let those biases shape that exchange between you and that individual? Or are you going to be open to this process and help your client to grow, even though you may not agree with everything that the client is saying? So it sensitizes not only you to the client, but it sensitizes you to yourself. One of the hardest things to do is to look at yourself introspectively, and say, maybe I need to change the way I think a little bit. Not necessarily how you think about spirituality, but just how I think about everybody else. You know, and give them opportunity to think the way they want to think. Like I say, as long as it's kind of normatively appropriate, if they come in and say, well, everybody is, you know, needs to be painted orange, well, that, you know, we don't want that to happen, right? But, you know, as long as it's normatively appropriate, then we can fly with it. Okay, so cultural biases. Discussion of the cultural context, relevance, and variation in spirituality and religious practices in local and regional communities. So we talked about the cultural context. We said that there, you know, recovery and wellness and spirituality and all these things, and you know, the mental health context and the interrelationship between mental health and spirituality. It's a growing phenomenon. It's not something that's shrinking, it's growing. You can find it throughout the literature. You know, just do a Google search, do a Google Scholar. Everybody know how to do Google Scholar? You do Google and pull down the more screen, and just, it'll give you a Google Scholar. Go into Scholar, and you get plenty of articles, peer-reviewed articles on you know, spirituality, mental health. You know, whatever you want to look up, we'll give you some peer-reviewed scholarship on that information. But you know, start reading up on it. You know, you want to be in tune. You want to be educated. You want to learn more. You want to be able to help more. You want to be stronger in this field. You know, it takes a little study, takes a little bit of insight, and that's the way it works. Kumar.
And we talked about these, and I thought the last one was pretty important. You know, because our definition originally of purpose and meaning in life, and our context for this whole thing is cultural competency and the recovery model. So I thought that was very important. This is a group decided they wanted to put that as a specific bullet in the training, understanding and noting how clients describe the quality and meaning of the experience as they relate to spiritual and mental health practices. I want to jump from here to the handout you had, the single page that was on your sheet. If you look at it, there are 6 competencies that our training plan came up with. It's broken up into introductory, intermediate, and advanced, like I mentioned before. This is by no means addresses all our needs. And I'll tell you one of the things that we got feedback when we rolled out our introductory trainings is that we focused on the intermediate and advanced on people who are within their scope of practice, can do assessments and plans, treatment plans, etc. But there's paraprofessional staff that provide a lot of case management support. There are peer staff that provide support and referrals. They all do a lot of support and linkage to the community, and they need to know about the boundaries and all the other thing, interaction, how to lead discussion groups, you know. And then somebody asked about, Phyllis asked about spirituality groups. It comes up in other groups apparently. I mean, we had one group in Hollywood Mental Health that's called Stress Reduction Group, and I happen to know the person who started it, and now they're continuing on, they've trained someone else. Spirituality comes up in that group a lot. Everybody shares, but it's called a stress reduction group. So, you know, we want to say do certain things, but not do certain other things. So we want to give more training to our paraprofessional staff also. So the introductory part is kind of what the first points Dr. Lewis mentioned. We want general rationale. We want them to understand why are we doing this, because a lot of times systems get the question back from practitioners, why are you asking me to do this? It's possible that in their context this may not have come up, but that's very rare, because when we ask our audience how many times it's come up, almost all of them raise their hand and said spirituality has come up in the interaction with clients. So, but still we wanted to make sure they understood the rationale. Then we wanted to also talk about that factors, you know, that this is not about prayer, etc., because that's not our domain. This is more about focusing on coping skills. That's the prayer is Chaplain James's domain. Ours is more about coping skills, more about locus of control, social support, etc.
Assessment methodology tools. There are organizations that are working on tools to help clients. You know, similarly, like you've heard of RAP and the toolkit, the RAP toolkit. You know, what clients can use in the event they're having a problem. They can refer back to a toolkit and, you know, use this, referring to spiritual advisors, referring to this. It might include prayer for them, you know, but a toolkit and things of that nature, tools to help them to overcome relapse and things of that nature when they're having decompensating in one way or another. Identifying clients' spiritual resources, strengths, documenting relevant information. Let's move on. Exercising cultural sensitivity, adhering to boundaries. Let's go to competency 5, cultural nuances and course formulation. We talked about that. Differentiating spiritual problems. That's problem definitions. Culturally competent recovery plans. We talked about that. Culturally relevant care coordination plans. We talked about that. So, you know, we covered a lot of ground. This is probably a longer training than we had today. But, you know, we did what we could with the time that we had. And let's just keep learning together. Let's keep supporting one another in this thing and, you know, doing the best job we can and, you know, consulting with one another to provide the most culturally competent, spiritually based, and, you know, mental health driven services that we can. Let's let Kumar have the last word.
Just want to point out that I'm supposed to tell you what our DMH practice parameters, the general guidelines for those staff that are here, but they do have a legal connotation. It can be produced in a court of law if asked. The department is asked, did you provide your staff with some guidelines? And hence the parameters for considerations for the spiritual interests of clients is in that sense an official document. It's undergoing revision, and also we are coming up with a policy that's in the works that specifically talks about some of the do's and don'ts for staff about integration of spiritual interests. So I just wanted to make that announcement. Great, thank you very much. Thank you.